I think, Ramal, it is already 6 p.m. in India. We can start.
Okay, great. Thank you so much, Dr. Kaushik, for your continuous support and help for everyone in the group. Thank you so much. So, hello, everybody. Thank you for having me. I'm very glad to have this opportunity. So, I thought I will make it more of a review back to the basics about strabismus. So, during this session, I will discuss esotropia and exotropia. So it will be more of a discussion, and I will show all the necessary information about esotropia and exotropia for FRCS exam and also for other specialty exams. So starting with esotropia, esotropia, as we all know, it is inward deviation of the eye. And we have two types. So anyone could help me if I want to classify esotropia, how we can classify it? How to classify esotropia?
Yes, I will.
Yes,
So
tell
it
me.
is divided into accommodative and non-accommodative. And in accommodative, it is refractive and non-refractive. In refractive, we have refractive, accommodative, and uh, uh, partial accommodated. And in non-refractive, we have hypo-accommodative and convergence excess. And then in non-accommodative, we have infantile esotropia and conjunctive esotropia and convergence excess esotropia and divergence deficiency esotropia and sensory esotropia.
Anything else?
Concomitant, concomitant, and
Yes.
concomitant can be paralytic or restrictive.
Yes.
In the concomitant, motor and sensory and consecutive.
Okay, great. So as you said, it's preferable to start with the very large classification to classify esotropia into comitant and incomitant. So once you did this, you will not forget anything. So regarding comitant esotropia, we have infantile esotropia, which usually will start since birth or within the first 6 months of life. Then we have other types of comitant esotropia, as you mentioned. We have accommodative esotropia. In the accommodative esotropia, we have fully refractive accommodative, partially accommodative, and non-refractive accommodative esotropia, which is high AC by A ratio esotropia or convergence excess esotropia. Also, we have sensory esotropia, and we have AACE, which is acute acquired comitant esotropia. Okay. In incomitant esotropia, as you mentioned, we have whether paralytic, like 6-nerve palsy, or restrictive, like heavy eye syndrome, Duane retraction syndrome, esotropic Duane retraction syndrome. Yes. So here is a patient with a comitant esotropia. So when we are saying
disease.
what does comitant means? What does the word comitant means?
Comitant means that the deviation is less in different gazes.
Comitant means that the angle of deviation remains same in all positions of gaze.
Yes,
and the free ocular mobility mobility.
Exactly. Those are the two criteria to say this is a comitant esotropia. The angle of deviation is equal in right gaze and left gaze. It is the same angle of deviation, primary right and left gaze equal. The second thing is full extraocular motility. Okay, incomitant esotropia, usually primary deviation. We have primary deviation and secondary deviation. Usually secondary deviation is larger than primary deviation. So how to measure the primary deviation? Anyone? How to
Yes, sir. तो मैं ये primary deviation we do the cover and uncover test.
Okay.
Prism cover test.
So
Prism
you will
cover
do-
test.
Yes, you will do alternate prism cover test to measure the angle of deviation. So in this case, the patient is having right esotropia, right complete 6 nerve palsy. See here in the primary position, patient is having right extra large esotropia. In right gaze, the right eye is not moving laterally. There is limitation of abduction, total limitation of abduction. In left gaze, it is okay. Am I right? So this is a patient with right complete 6 nerve palsy. So if you put the prism over the right eye, then you are measuring what?
Primary angle of deviation.
Primary deviation, exactly. And if I am putting the prism over the left eye, this is
Secondary deviation.
secondary deviation, exactly. So if I'm putting the prism over the right eye, this is the primary deviation. If I'm putting the prism over the left eye, this is the secondary deviation. Usually, the secondary deviation will be larger than the primary deviation. Okay, so this is regarding the concomitant esotropia. So here again, the same thing what I have already said, concomitant, concomitant. You need to remember this. Whenever anyone asks you about a case of esotropia, always remember to divide concomitant, concomitant, and under each one, you will memorize or you will enumerate the specific causes of esotropia. So let's start with this case. This is a patient who is 1.5, 1 year and a half, female, presented with inward deviation since birth. Okay. And on examination, fixation, she has central steady maintained fixation in both eyes. Alternate prism cover test at near esotropia around 40 prism diopter, full extraocular motility, anterior posterior segment normal, cycloplegic refraction done twice, and in both times it revealed only +1 hyperopia, very mild or low hyperopia. So what it could be?
It is
Diagnosis.
Infantile esotropia.
infantile esotropia, left eye.
Yeah, exactly. So this is a case of infantile esotropia. How did we know? Firstly, the history, the deviation started since birth. It is moderate
Large
angle,
angle.
esotropia, 40 prism diopter, full extraocular motility, and anterior segment normal. So if the same scenario and patient, for example, is having unilateral cataract or the patient is having retinoblastoma or anything else. So what is
Sensory.
Yes, in that case, that is a sensory esotropia. Okay. If the anterior posterior segment is normal, but the patient, when we did cycloplegic refraction, it revealed +4, +5 diopter hyperopia. So what is the diagnosis?
Refractive esotropia.
Accommodative.
Accommodative esotropia. But one of you will ask me, but the patient is having deviation since birth or shortly after birth. How it could be accommodative? There is an entity of accommodative esotropia which called early accommodative esotropia that will present earlier than usual. Okay. So in such case, what is the treatment? How would you manage?
We will give the full cycloplegic refraction and treat amblyopia if any. Then we'll decide the surgery.
Okay. So in such case, would you give these glasses or no need?
I will give.
No need.
No need.
+1. Do
No
you
need.
Yeah,
think
I will give.
No need.
+1 hyperopia will change anything for a patient who is 1 year old? So that is even less than normal for the age. So yeah, usually if the cycloplegic refraction revealed something less than +2, usually no need to give actually. Okay, so if it is +0.5, +1, +1.5, most probably it will not change anything in such angle. Okay, and as you mentioned, we need to treat amblyopia. So in such patient, how would you know if the patient is having amblyopia or not? He is 1 year old. you cannot test the visual acuity.
Preferential looking or
Okay.
occlusion
You-
of the right eye, and we look
you-
at if he will
Uh-huh.
be
We can also like differentiate it on the basis of EP, which
Okay, so there are methods to measure the visual acuity in infants, like preferential looking test, but unfortunately, it's not available in many clinics. Am I right? So what can you do? You can check
orthokinetic drum.
resistance to occlusion. For example, when you occlude the right eye, you check the behavior of the patient and occlude the left eye and check the behavior of the patient. If you feel the patient is having a resistance to occlusion of one of the eyes more than the other, then most probably this is the good eye. Okay? So that is one solution. The second solution in such patient, you will check the fixation preference. Fixation preference. What is fixation preference?
Which is the dominant eye, fixing eye.
Yes, so that is the CSM that I called CSM. So, for example, you will occlude the left eye. The right eye will be central and steady because the patient has no nystagmus. And then you will uncover the left eye and you will check the fixation in the right eye if the patient is still fixating or not. If he is fixating, still fixating with the right eye, even after uncovering the left eye, then the patient is having central, steady, maintained fixation in the right eye. Then I will do the opposite. I will occlude the right eye and I will check the fixation in the left eye. When I am closing the right eye, the patient will have central and steady fixation in the left eye. Then I will uncover the right eye. And if the patient is maintaining fixation in the left eye, even after uncovering the right eye, then the patient is having again central, steady, maintained fixation in the left eye. So in such cases, I will write fixation CSM-OU. That means patient is maintaining fixation with both eyes. And that is a sign that most probably vision is good in both eyes. Am I clear?
yes. Thank you.
Okay. So if the patient is having unmaintained fixation in one eye, for example, in this patient is having left esotropia. Whenever I close the right eye, patient will have central fixation in the left eye. Whenever I uncover the right eye, the left eye will go inside immediately. So that is a case of left constant esotropia. So most probably patient is having left amblyopia. Okay, most probably. So I will start with the occlusion therapy. I will do occlusion to the right eye till the patient is having alternate fixation or central steady maintained fixation in both eyes. Okay. So usually I will give full cycloplegic refraction in infantile esotropia, especially if the patient is having significant hyperopia, anything +2 or more. Secondly, I will treat amblyopia. Thirdly, I will do the surgery. So what is the preferred surgical procedure in this patient?
Major rectus
Major,
recession.
major perception.
Okay, so you will do it in one eye, both eyes,
Bilateral.
If the
bilateral.
angle is less than 15, I'll go for just one eye. If the angle is more than 15, I'll go for bilateral medial rectus recession.
Exactly,
pref-
exactly.
yeah.
But usually in such patient with infantile, usually angle will be larger than 15, usually 30, 40, 50, 60, and so on. So in such patient with esotropia 40 present diopter, how much can you do to alleviate this angle? How much bilateral medial rectus recession? Any suggestion? How much bilateral medial?
I think in such case, we will need also lateral rectus resection because it is large angle for bilateral medial rectus resection.
40 is moderate angle, you know. When we are talking about large angle, usually 50 plus 55.
Around 6 millimeter.
Yeah, see, if the patient is having partial accommodative esotropia, I would go for 6 millimeter. But for infantile esotropia, usually we go for lesser numbers. So in this patient, I have done 5 millimeter, sorry, 5.5 millimeter of BMR. Okay, 5.5 millimeter. Okay, so here are,
Sir, why we are going for lesser numbers? Like, what is the reason, sir?
actually the dose in infants or in small children will be more powerful, right? 1 millimeter of
Okay,
medial rectus recession in smaller children will give you more correction.
okay,
If you go
okay,
for larger number, then you might end up with consecutive exotropia or overcorrection.
okay.
Okay.
Thank
So
you.
Even for
uh,
So
infantile
the
exotropia,
are these numbers are important for the exam? How many milli we have to resect or
see,
such?
I have seen some of the previous exam experiences where they asked the candidate, for example, for each millimeter of recession, like medial rectus recession, each millimeter will correct how much. So usually they will not ask specifically. You don't need to memorize the tables. Even strabismologists are not memorizing the tables, but you need to know, roughly. For MR recession, usually 1 millimeter will correct around 3 prism diopter. For lateral rectus, usually 1 millimeter of recession or resection will correct around 2 prism diopter. For vertical, whether superior or inferior rectus, recession or resection, 1 millimeter will correct around 3 prism diopter. So that's all that you need to know. But for specific numbers, I don't think.
So is it
Okay.
for recession or resection or both?
Recession or resection.
Okay.
Usually medial rectus, the dosage, like the effect of the recession or resection per millimeter will be more powerful than lateral rectus. Okay.
Okay.
Yeah. So here again, I will just go through the clinical features briefly. So usually infantile esotropia patient will be neurologically normal, equal visual acuity with amblyopia in less than half of the patients, large constant esotropia, usually more than 30 prism diopter, low hyperop usually, and DVD and inferior oblique overaction in a large percentage of the patients. But when DVD and inferior oblique overaction will start and latent nystagmus, when it will present in infantile esotropic patient.
So it
DVD.
presents later on in life.
Yes,
Like
yes. Usually DVD, inferior oblique overaction, latent nystagmus will present after the age of 2 years. After the age of 2 years. Okay. Also monocular smooth pursuit asymmetry. That is when we are using the optokinetic drum monocularly, nasal to temporal and temporal to nasal. There is asymmetry, and that is due to loss of fusion in a very early age. So also patient with infantile esotropia, many of them will have something called cross fixation. So when the patient is looking on the left gaze, he will use the right eye. And when the patient is looking at the right gaze, he will use the left eye. Okay? Here again, patient is looking at the right gaze, he is using the left eye. Patient is looking at the left gaze, he is using the right eye. So what cross fixation denotes? If the patient is having cross fixation, that telling you something. What is it?
It's not amblyopia is not there. Almost equal vision in both eyes.
Most probably patient is having equal vision. Mostly. Okay, great. Inferior oblique overaction is a very common association with infantile esotropia and also other type of strabismus. So usually patient will have over elevation on adduction. Over elevation on adduction. Here the patient is having more inferior oblique overaction in the right eye. Also DVD, dissociated vertical deviation. You can see here the eye is drifting upward under the Spillman occluder. management, as we mentioned, correction of the refractive error, amblyopia treatment, and sometimes botulinum toxin can be used as an alternative in a small angle esotropia or moderate angle, or augmentation. Augmentation means what?
If there is
Mean-
a residual angle after the surgery, mean under correction after the surgery for small angle, so we can inject botulinum toxin in the lateral rectus and leave the medial rectus to take the upper hand for these months until it is strengthened.
Yes, or even intraoperatively. For example, patient is having esotropia 60 or 70 prism diopter large angle. You can do bilateral medial rectus recession, for example, 5.5 or 6 millimeter recession, and you inject botulinum in the muscle intraoperatively. So injecting botulinum will augment the surgery, will increase the efficacy of the surgery, will correct more esotropia. Okay. So surgical options, as you mentioned, bilateral medial rectus recession is the best. But in patients with severe amblyopia, we can go for unilateral recess resect, unilateral medial rectus recession and lateral rectus resection. Timing of the surgery, very early. Some strabismologists are doing surgery very early, within the age of 2 to 6 months. Early, 6 to 24 months before the age of 2 years, and late after 2 years. So these are three schools when to do the surgery for patient with infantile esotropia. What are the
Dr.
complications?
Amr, what are
Yes.
the cases in which we want to augment by Botox? Because that is for short term. Botox the effect will go away after
Yes.
3 to 6 months. So why would we want to augment
Okay.
rather
So,
than doing it better?
yes. So if the patient is having esotropia 55 prism diopter or 60 prism diopter or more, the maximum medial rectus recession will not be enough. So you have two options, whether to do a third muscle, a unilateral lateral rectus resection in addition to bilateral medial rectus recession, or you can do bilateral medial rectus recession and you inject botulinum in the muscle. As you said, botulinum have a transient effect. It will work for 3 to 6 months, then it will wean off. The good thing about infantile esotropia, if the patient is orthotropic post-operatively for 3 to 6 months, he might maintain fusion after that, even after the botulinum toxin will wean off. Because of that, sometimes we do augmented recession with botulinum toxin rather than going for a third muscle. Okay, and sometimes the patient after 6 months will have a residual esotropia, then you can do a third muscle. Okay.
Okay.
So it is a way to avoid doing third muscle in the primary surgery. Why
Okay.
avoiding the third muscle? To avoid the risk of consecutive exotropia.
Okay.
Okay, overcorrection. So regarding complications of the surgery, what are the complications?
So there
Complication.
are,
Undercorrection, overcorrection,
there are intraoperative complications and
hyperthermia.
postoperative complications. Intraoperative complications like hyperthermia, like scleral perforation, hemorrhage, and postoperative complication like undercorrection, medial rectus slippage, or medial rectus lost,
Okay.
granuloma.
Okay. Yes.
Diplopia.
Ocular
Yes,
ischemic
segment
syndrome
ischemia.
if more than 2 muscles. Ocular ischemic syndrome if more than 2 muscles.
If more
Overcorrection.
than two muscles in one eye. If more than two muscles in one eye. If I did three or more recti muscles in one eye, I might get intersegment ischemia. Okay.
Yeah.
Okay. Okay. So as you said, we might have undercorrections. Okay. Or overcorrections. overcorrections, we have two types. Whether early overcorrection with limitation of adduction, so that will raise the concern of slippage, muscle slippage, or we can have later overcorrection, which might happen because of the dosage of the surgery or a stretched scar. Other surgical complications, as you mentioned, globe perforation, RD following globe perforation, orbital cellulitis, endophthalmitis, anterior segment ischemia, lost muscle, slipped muscle, conjunctival cyst, pyogenic granuloma, corneal Dillon. Of course, many of these complications are very rare, like globe perforation 1 in 1,000, RD following globe perforation 1 in 25,000. Okay, endophthalmitis 1 in 30,000. So it is a very rare complications, but still it can happen. Okay. Okay. Coming to the second case. So this is a patient with 6-year-old male presented with inward deviation since the age of 3 years. So the problem started at the age of 3 years. On examination, vision 6.6 in the right eye, 6.12 in the left eye, fixation central steady maintained in the right eye, central steady unmaintained in the left eye. Without glasses, the alternate prism cover test, SC means without glasses. Alternate prism cover test at near, esotropia 30 prism diopter. Without glasses, alternate prism cover test at distance, patient is having esotropia 25 prism diopter. Full extraocular motility, anterior segment, posterior segment normal, cycloplegic refraction revealed +5 diopter, hyperopia. So what is the diagnosis here?
Accommodative esotropia.
Accommodative esotropia. So if I told you that the patient now is having esophoria of 8 prism diopter at near and at distance with glasses. So what is the
Partially
diagnosis?
accommodative esotropia.
Partially
Accommodative.
accommodative esotropia.
Only 8 prism diopter remaining. So is it partially or something else? So if the patient is having residual esophoria or esotropia, something within 8 to 10 prism diopter, that is still
Microtropia.
going in, we can say that this is a fully refractive accommodative esotropia. If the patient is having residual of 8 to 10 prism diopter, not more than that, that is going under the fully refractive accommodative esotropia. If the patient is having more than 10 prism diopter of ESO with the full cycloplegic refraction, then this is a partially accommodative esotropia.
So can we say it like microtropia also? Because it is
Yes.
within 10. Yes.
Yes. But in the large classification, whether it is fully or partially, this is considered fully refractive accommodative, and you don't need to do anything for that residual 8 prism diopter or something. Okay. Usually we don't do surgery for such small angle. So in this patient, we give the full hyperopic correction, and because the patient is having mild hyperopia, mild amblyopia, sorry, in the left eye, we do also right eye patching 2 hours daily. So this is the picture of the patient without glasses. You can see angle of deviation, the around 30 prism diopter, the light reflects on the pupillary border, and with glasses, patient is orthotropic. So this is fully refractive accommodative esotropia. So in such patient, the only treatment is glasses, nothing else, nothing to be done. So
Doctor, please, about the difference of angle of deviation between near and far. When
Yes.
I can expect there is convergence excess.
Yes, if the difference between near and distance, something within 10 prism diopter, that is considered basic esotropia. So if the patient is having esotropia at near 30, esotropia at distance 20, 25, that is basic esotropia. But if the difference is more than 10 prism diopter, for example, at near 40 prism diopter, at distance 20 prism diopter or 25, so this is high AC by A ratio esotropia or convergence excess. So
Okay, thank
Okay.
yeah,
So
the
can
Here
you
difference
we can
kindly
use
repeat?
prism diopter.
again,
Yes,
please.
Can you
the
please kindly
difference.
repeat the difference between?
The difference should be more than 10 prism diopter. Anything within 10 prism diopter difference, usually we say that is a basic esotropia, basic exotropia. But if the difference is more than 10 prism diopter, if it is more at near, so this is convergence excess or high AC by A ratio. If the distance deviation is more, so this is divergence insufficiency or paralytic type of esotropy. Okay.
Thank you, sir. Thank you, sir. Yes.
Okay. So here just a refreshment about what we have already said: refractive, non-refractive, partial accommodative, or decompensated. Decompensated means that the patient, when you give the glasses initially, the patient become orthotropic or with microtropia with an 8 prism diopter. But with time, again, the esotropia increased. So that what we call usually decompensated. Okay. So for accommodative esotropia, usually the onset around between 6 months and 7 years. The average 2 to 5 years. Intermittent at onset, then become constant over time. Often initiated by illness or trauma. Why? Why many patients, many parents will tell you, my child was good, was having a straight eye. After he had a head trauma or after he had fever, the esotropia started. Why?
Because it was compensated,
Okay.
centrally compensated.
So what happened usually if the patient in the normal status, he can fuse with both eyes and he can control the esotropia. But once the patient became ill, he will lose that control and esotropia will be more prominent. Okay. Because of illness, the fusion and the control of the deviation will be lesser. Because of that, usually parents or family will start to notice the ESO deviation or also the exo deviation after the patient became ill or after head trauma or after trauma. Okay.
So, what is the horizontal fusional amplitude, sir, after which it becomes decompensated?
Horizontal fusional amplitude, that is, we have two actually. We have something called convergence amplitude and divergence amplitude. So the normal convergence amplitude, that is usually 25 to 30 prism diopter at near and little lesser at distance. And for divergence fusional amplitude, that is usually 6 to 8 prism diopter. That is the normal fusional amplitude in all people, in the normal population. Okay.
Thank you, sir.
Thank you. So also accommodative esotropia frequently associated with amblyopia, and sometimes it has a hereditary base. You will find that the child, his siblings, his father, his mother also having the same problem. Okay. So mechanism of accommodative esotropia, whether uncorrected hyperopia or high AC by A ratio, accommodative convergence is high, or poor fusional divergence. And that is the least important factor. Those are the two most important factors. So refractive accommodative ET, history of acquired intermittent or constant ESO, usually at the age of 2 to 3 years, as we mentioned. Some parents will report that the patient is having a straight eye sometimes, but when the patient focusing at near, the esotropia will be more prominent. Okay. Also, older children will have some astenopic symptoms, headache. Average psychoplastic refraction usually a plus 4.75 plus 5 diopter. So I have a question here. For the patients with high hyperopia, for example, plus 9, plus 10 diopters, do you think they will have esotropia or not? Patient with high hyperopia, plus 9, plus 10.
Maybe not because he has bilateral amblyopia.
Okay, so he
But
will
that
have,
much power he cannot adjust with just by convergence. So he won't have.
yes, exactly. So usually patient with very high hyperopia, plus 9, plus 10, he cannot overcome the high numbers. So whenever he will do convergence, he will not see a clear image. Because of that, usually patient with high hyperopia will have hypoaccommodation and they will have a straight eyes. Okay? Patient with high hyperopia plus 9, plus 10, many of them will have hypoaccommodation and they will have a straight eyes. And of course, bilateral amblyopia, as you mentioned. So usually patient with refractive accommodative esotropia will have hyperopia. Angle of squint usually between 20 and 40 prism diopter. Distance and near deviation are equal or within 10 prism diopter. And when esotropia becomes constant, amblyopia develops, especially with unmaintained fixation in one of the eyes. Management of refractive accommodative esotropia, as we mentioned, full cycloplegic refraction. Glasses must be worn full time with part time. Wearing accommodation will not be relaxed and vision will be blurred. So the patient should wear the glasses full time. Okay. And re-evaluation after 1 to 2 months. If ET is fully corrected within 8 to 10 prism diopter for near and distance, so the patient is having fully refractive. If distance and near esotropia still noted to be high, the first thing to be done is to repeat cycloplegic refraction to make sure that the patient is taking the full hyperopic correction. If still significant, then the patient is having partially accommodative esotropia. If the patient is having orthotropia or a small angle of deviation at distance, for example, 8 prism diopter at distance, but having a high or larger esotropia at near, so that is a patient with high AC by A ratio. Okay, we can skip this. Actually, here we are just speaking about the natural history of patient with refractive accommodative esotropia. So usually the numbers will decrease with the patient growing. And usually if the patient is having good alignment and good vision in both eyes, we will start reducing the hyperopic correction plus 0.5 to plus 0.75, okay, annually, to weaning off the spectacles or decrease the spectacle numbers. Okay, case number 3, 7-year-old female presented with inward deviation since the age of 2 years. On examination, best corrected visual acuity 612 in right eye, 6.9 in the left eye. Fixation central steady maintained in the right eye, central steady unmaintained in the left eye. Alternate prism cover test at near esotropia of 55 and at distance esotropia of 45. With glasses, CC, with glasses, we repeated the alternate prism cover test. The patient has esotropia of 30 prism diopter at near and 30 prism diopter at distance. Also, the patient had inferior oblique overaction plus 2, anterior posterior segment normal, cycloplegic refraction revealed plus 8 diopter hyperopia. So what is the diagnosis here?
Partially accommodative.
Yes, that is a case of partially accommodative esotropia. Why partially accommodative? Because even after giving the full cycloplegic refraction, patient still having large esotropia. Anything larger than 10 prism diopter, that is partially accommodative esotropia. So what we will do for this patient?
We will do
Bifocal
surgery
glass.
for the residual angle.
We will
Again, sorry.
search for the residual strabismus.
We will do surgery for the residual angle and surgery for the inferior oblique.
Yes, exactly. So you will do the surgery for the 30 or the 55?
No, for 30.
For 30.
For, yes, exactly. So we will do the surgery for the residual angle that is not corrected by glasses. And we will counsel the parents that the patient will need glasses after the surgery. And because patient is having significant inferior oblique overaction, I also will do inferior oblique weakening procedure. So here I did bilateral directed recession 4.5 millimeter with inferior oblique recession in both eyes. You can figure out here that the patient is having large hyperopia, magnifying lenses. Okay.
So I have a
So,
question.
yes.
The right eye is best corrected by 612, so it is more amblyopic than the left eye. So will we do surgery on the right eye only or both eyes?
See, the difference here is not that big. The difference is small. Like the patient is having amblyopia, but mild amblyopia. So in such cases, it's preferable to do symmetrical surgery. You can do bilateral medirectus recession, and definitely you will do patching of the left eye for few months till the vision is equal in both eyes.
Okay, thank you,
Okay.
sir.
Then
Yes, sir.
why
but
this why this fixation in the right eye is central study maintained and in the left eye it is unmaintained, although the vision best corrected is better in the left eye?
Yeah, I think that is only a mistake in the writing. Yes, the patient is having unmaintained in the right eye. I am sorry about this. Okay, so this is just a mistake. Usually, the patient will have unmaintained fixation in the poor vision eye, the eye with poorer vision. Okay.
Yeah. Is
Yeah.
this 6/12 vision is enough to have an unmaintained, because 6/12 comes in
Yes.
moderate amblyopia. It will start moderate amblyopia. So
But
for unmaintained, it should be severe, right? Or it can be with the moderate also, it will become unmaintained.
yes, not necessarily, even with mild amblyopia. Even some patients, interestingly, even some patients with partially accommodative esotropia that I started to giving them glasses, okay, and examining the vision after glasses, they even might have equal vision in both eyes, but they prefer fixation with one of the eyes. So it is not necessarily to have severe amblyopia in the eye with unmaintained fixation. Okay. But
Okay.
definitely, whenever you have unmaintained fixation and you cannot measure the visual acuity, you need to start patching the maintained eye, the good eye, the
Okay.
preferred eye. Okay. So, as we mentioned, management of partially or decompensated accommodative esotropia, usually we give the full hyperopic correction, treat pre-existing amblyopia, and BMR is the preferred procedure unless the patient is having severe amblyopia and the patient is old, like 9 years, 10 years, beyond the age that amblyopia can be treated completely, then we can do unilateral recess resect. And we need to counsel the patient, the family, about surgery would not completely eliminate use of glasses, but align eyes with glasses. Then coming to the surgical formulas for a patient with partially accommodative esotropia. So we have many formulas. One of them is standard, the residual deviation. For example, in the previous patient, 30 prism diopter, we will aim for 30 prism diopter correction with the surgery. In some patients, we might need to do something called augmented surgery. So that is the near deviation with glasses plus near deviation without glasses divided by 2, and we will take the mean deviation between near deviation with and without glasses. For example, in that patient here, near deviation without glasses 55, near deviation with glasses 30. So 55 plus 30, that is 85. So 85 divided by 2, that is 42. Okay. So in some patients or some doctors might prefer to do augmented surgery. In patient with high AC by A ratio, we have another augmented surgery. We take near deviation without glasses plus distance deviation with glasses divided by 2. Or we can do simply Faden plus recession, and I will talk about this in details in the coming slides. Okay, case number 4, 7-year-old male presented with inward deviation since 3 years. On examination, best corrected visual acuity 612 in right eye, 615 in left eye, CSM right eye, CS unmaintained in the left eye. Without glasses, patient is having esotropia 50 at near and esotropia 25 at distance. And with glasses, patient is having esotropia at near 30 prism diopter and esotropia at distance 8 prism diopter. So what is the diagnosis?
It is a non-accommodative esotropia with high AC ratio.
Yes. So that is a patient with high AC by A ratio, esotropia. With glasses, the patient at distance is having good alignment, but still is having large ESO deviation at near. So what can be done for this patient?
Bifocal lens
bifocal
cycloplegic
glasses.
refraction.
Yes, exactly. So if the patient is having good alignment at distance with the full cycloplegic refraction, do not do surgery. You just need to give bifocal glasses. That will be more than enough. Okay. So this is the patient. You can see here at near, he has a large deviation with the distance segment of the glasses. But with the near segment, the bifocal segment, is having a straight eyes. Okay. So that is one type of patient with high AC by A ratio. So if the patient is having good alignment at distance with the glasses, we will just add bifocal to manage the residual ESO at near. But if the patient is having large esotropia at near and at distance, what could be done?
Surgery.
Yes.
Basically.
Yes. In such patient, for example, this patient with glasses is having, for example, esotropia 50 at near and 30 at distance. Okay. So in such patient, I will go for surgery because even with bifocal glasses, he will still have esotropia, large esotropia at near and at distance, more than 10 prism diopter. Okay. Okay. So this is
Sir,
a case that
so when do we, sir, when do we when do you decide on giving bifocals, and when do you go for surgery, or you give bifocals and then you wait and see the correction and then decide on surgery?
okay. So see, in such patient, the esotropia at distance with the glasses is 8 prism diopter. So here the patient is having a good alignment at distance.
Okay.
The only problem is at near. So in such patient, you can start with bifocal glasses. Okay.
Okay.
But if the patient with full cycloplegic refraction is having a significant esotropia at near and at distance, so even with giving bifocal glasses, that will not solve the problem at distance. Am I right?
Right. Right.
So
Right.
in such
Correct.
cases, you need to do surgery. Okay.
Okay.
What type of surgery? Usually we do bilateral medial rectus recession aiming for the angle at distance, and we will do something called Faden procedure or posterior fixation suture to treat the residual angle at near. Okay?
Okay.
Yeah, here that is a case of 13-year-old female with inward deviation since the age of 5 years. On examination, vision 6.6, she's having esotropia 45 prism diopter at near and 25 prism diopter at distance. Full extraocular motility, anterior segment normal. Cycloplegic refraction was only plus 0.75. That's it, nothing more. And we repeat the cycloplegic refraction 2 times. Very small hypermetropia. Okay? So what is this case? What is the diagnosis?
Convergence excess esotropia.
Yes, high AC by ratio or convergence excess esotropia. So what can be done for this patient?
We can give prism to this patient.
Okay, is it a final treatment or that is a temporary treatment?
It's a temporary.
And would you give a prism for the 45 or for the 25?
I think for the 45 it should be given. I'm not sure.
But then for the distance patient will have exo. Am I right? Because
Yeah,
we have a distance. So I think prism here will not be a very good option.
Bifocals?
Okay, bifocal patient is having only plus 0.75. So let's say I will give plus 0.75 at distance and plus 3.25 at near. Okay? Do you think plus 0.75 will treat 25 prism diopter of ESO?
No.
No, at all. That is nothing. Plus 0.75 is nothing for a patient who is 13-year-old. 13-year-old, okay? That will not do anything, unfortunately. So what can be done?
Bilateral medial rectus recession also is Faden.
Yes, yes. So in such case, I did bilateral medial rectus recession. The target angle is the 25. I will do only for the 25, okay? And I will do Faden procedure to treat the residual esotropia at near.
okay.
So here I did 4 millimeter recession with Faden procedure. That is the patient preoperatively and post-operatively. Okay.
What is the significance like Faden procedure if we do? That will correct the residual, that will correct only a small angle. That is why we add up with Faden.
The thing, if you aim for, if you did only bilateral medial rectus recession and you aim for 25 only, then the patient will have residual esotropia at near 20. Okay.
Okay.
If you aim for 45 prism diopter bilateral medial rectus recession to treat the 45, patient will have residual, will have consecutive exotropia 20 prism diopter at distance.
Yeah.
So we do BMR for the 25 and the Faden, those posterior fixation suture, we put in a non-absorbable suture 12 millimeter from the medial rectus insertion. That will decrease the convergence at near. So
Okay.
it will treat the convergence excess at near. Okay. So in such patient, now patient is having a good alignment at near and at distance, without having overcorrection at distance or without having undercorrection at near. Okay.
They say Faden procedure we are also doing in the essential infantile esotropia, which has superior rectus, which has DVD for superior rectus. So the mechanism is the same. Like we are doing again posterior fixation suture. Then how will that one will work? Because here, so it is working with the improving the convergence. But how it works there, and what is the mechanism? Basic principle.
I will tell you. So for convergence excess esotropia, the Faden procedure will help in decreasing the convergence at near. Okay. For DVD, patient with infantile esotropia with dissociated vertical deviation. To treat the dissociated vertical deviation, sometimes we do superior rectus Faden. So we do posterior fixation suture to the superior rectus, and that again will help in having lesser hyper hyper deviation in the eye to decrease the DVD without affecting the alignment of the eye. The Faden will not cause vertical deviation. Okay?
Okay.
It will not
Okay.
cause hypotropia in the eye that you will do Faden on it for the superior rectus, but it will help in reducing the dissociated vertical deviation.
Okay.
Yes.
And here also it will do the same thing. I mean, it is not helping in recession. It is not helping, like it is not weakening procedure.
It is
Is
a
it?
weakening procedure.
So it weakens partly because we are giving posterior fixation suture. I mean, because here when you did for 20, it will, you said it will work only for near
It will
vision.
only for near, yes. It has a different mechanism for the superior rectus and for the medial rectus. For the medial rectus, you are aiming for decreasing the convergence at near. So you are doing Faden to help you in treating the residual angle of deviation. For the superior rectus, it will help you in relieving the DVD
Okay.
without affecting the primary position of the eye. It will not cause hypotropia.
Okay.
Yes.
Okay. 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 Thank you.
So that is the same thing that we already mentioned. I will just go through it fast. Yes. So as we mentioned, bifocals is a very important management option. If the patient is having, if the patient is orthotropic or within 8 to 10 prism diopter at distance, then you can do the bifocal. Surgery, if the patient is having more than 10 prism diopter esotropia at distance with the glasses, then you will use surgery with Faden. That is the summary. Full cycloplegic correction, esotropia, less than 8 to 10 prism diopter for distance and near. That is a refractive accommodative esotropia. If the patient is having esotropia more than 8 to 10 prism diopter for distance and near, that is partially accommodative esotropia. If the patient is having esotropia less than 8 at distance and more than 8 to 10 at near, that is non-refractive accommodative esotropia or high AC by A ratio. Then we will come to something called acute acquired comitant esotropia. So usually it presents in older patient, usually more than 5-year-old of age. Patient will present with acute esotropia, diplopia in some of the patients, comitant deviation. So that will differentiate this problem from 6-nerve palsy. Those patient is having a comitant deviation and full extraocular motility. So acute acquired comitant esotropia, we have 3 classical types: the Burian type, that will happen usually after monocular vision loss or prolonged patching of one of the eyes. Franchisti type, usually there is a positive family history. And the patient mostly is having a decompensated esotropia, or Belchovsky type, usually patient will have a myopia rather than hypermetropia. And there are other types of acute acquired comitant esotropia also in the new classifications. Most importantly, in a patient with acute acquired comitant esotropia, what? What do you need to know about those patients? Any idea?
Neurological issues.
Exactly. Such patient, you need to rule out any neurological problems, because some of those patients with acute acquired comitant esotropia might have a brain tumor or hydrocephalus. So you need to rule out any neurological disease. So if the patient has no history of strabismus, occlusion therapy, monocular vision loss, myopia, then if there is no apparent cause of the acute acquired comitant esotropia, you need to rule out neurological disorder. Other signs or symptoms that will help you to know if the patient might have neurological disorder, what? Other signs?
Restricted extraocular motility.
That is not acute acquired comitant. Now we will go for the sixth nerve. But if the patient is having comitant deviation,
Restricted, but in there won't be any restricted movement.
those patients will come with full extraocular motility, but still they might have neurological problems. So what are the other signs that if it present, it will help me in knowing that those patients might have a neurological disorder? Other signs.
Increase in intracranial tension center.
Nystagmus.
Nystagmus, one. A pattern, pattern deviation, especially A pattern. Abnormal fundus examination, papilledema, for example.
Pupil and field defect.
Pupillary problems, field defect. Other neurological problems with motor function, coordination. All these things will tell me that the patient might have a neurological disorder. So if I am suspecting neurological disorder, what I will do?
MRI.
Yes, exactly. Brain MRI. You need to do neuroimaging, brain MRI, to know what is happening. So management of acute acquired comitant esotropia. Firstly, you need to rule out neurological problems, especially patient with nystagmus, poor fusional potential, other motor abnormalities. You need to do urgent neurological evaluation plus imaging. Frequent evaluation of the patient to know what is happening, if the angle of deviation is increasing, if the angle of deviation is decreasing, if the patient started developing limitation of extraocular motility. So you need to do frequent evaluation of those patients. Surgical management after having stable alignment, then you might go for bilateral medirectus recession. I will show you one case now. So this is a case of 22-year-old male, systemically free, presented with inward deviation and double vision since 3 years. On examination, vision 6.6, fixation central steady unmaintained in the right eye, central steady maintained in the left eye. Angle of deviation was 25 to 30 prism diopter of ESO at near and 30 prism diopter of esotropia at distance. Full extraocular motility. Patient is having uncrossed diplopia. What does that mean?
Uncrossed diplopia is with the exotropia.
Esotropia.
Esotropia. Yeah,
Yes.
esotropia.
So if I put the red filter lens over the right eye, where is the image with the red color? Where is the image with the white color in uncrossed diplopia?
Same side.
Right.
Yes. So if I put red filter lens over the right eye, the patient will see the right image in a red color and the left image in a white color. So that is the uncrossed diplopia, which usually will present with patient with esotropia. And the crossed diplopia will happen in patient with exotropia. And usually the red image will be on the left side. The white image will be on the right side, crossed. Okay?
Yeah.
So this patient is having uncrossed diplopia and he is fusing with 30 prism diopter base out at near and distance. So what did we do for this patient? After examining the anterior segment, posterior segment, it was normal. I checked other cranial nerves to make sure that there are no any other cranial nerve pulses. Cycloplegic refraction, actually here, it was minus 0.25 diopter. Okay. MRI brain done, it was normal. Patient was followed for 6 months with stable deviation. Then I did surgery for the patient, bilateral medial rectus recession using adjustable suture technique. So why this is important here?
To readjust the amount.
Yes, why? Why it
To
is
avoid
Then
consecutive, to avoid
called
consecutive exotropia.
diplopia to
okay?
diplopia because he has diplopia.
Yes.
When the
Remember,
outcome is unpredictable, they do this.
yes, remember this is a patient with good vision in both eyes, and he's having fusion. Because of that, he's having diplopia. So you need to do a perfect surgery so the patient will not have diplopia postoperatively. So because of that, usually in such patient, we do adjustable suture technique to make sure that the patient is having, patient does not have any diplopia at near or at distance. Okay? Okay. So also there is something called residual esotropia or undercorrected esotropia. So those patients usually had esotropia and did surgery, and after the surgery they have residual ET. So if the patient is having small undercorrection, something within 8 to 10 prism diopter, usually we don't do anything. It is considered acceptable. But if the patient is having larger residual ESO, then that is not acceptable, and usually we do surgery for those patients. So if the patient is having initial bilateral medial rectus recession, usually we do lateral rectus resection. If the patient is having initially unilateral medial rectus recession plus lateral rectus resection, we do the same approach on the second eye. Okay, is it clear?
Yeah.
Okay.
Sir, can you repeat this one? I couldn't understand.
Yeah. So those patients with residual esotropia, we have two classes or two groups. One of the groups is a patient with small residual esotropia, something within 8 to 10 prism diopter. Usually we do not do anything for those patients.
Okay.
If the patient is having larger esotropia, then it is considered not acceptable, and we might need to do another surgery to treat the residual ESO. Okay? So if the
Okay.
patient initially
Okay.
had bilateral medial rectus recession, then you need to work on the lateral rectus muscle. We will do lateral rectus resection. If the patient initially had unilateral medial rectus recession and lateral rectus resection, then you will do the same approach, unilateral recess resect on the second eye, on the untouched eye. Okay?
So we'll do the resection with resection on the other eye,
Yes,
or just resection.
if the primary surgery was unilateral recess resect on one of the eyes, then you will do the surgery on the other eye, recess resect. If the patient initially had
Okay.
bilateral medial rectus recession, then you will work on lateral
Only live
recti,
resection.
whether one muscle, depending on the residual angle.
Right. Right. Thank you.
Okay. So this is a case of 80-year-old female presented with inward deviation since the age of 2 years. She had a past history of bilateral medial rectus recession 4 years ago. And on examination, vision is good, 6/9, both eyes. Cycloplegic refraction +3. With glasses, patient still is having residual angle of 35 prism diopter. Esotropia, 35 prism diopter. Full extraocular motility. Anterior posterior segment normal. Impression residual esotropia. So what can be done in this case?
Lateral rectus resection.
Yes,
According
lateral
to
rectus
the
resection.
previous procedure.
Yes, here is the previous procedure. BMRC, bilateral medial rectus recession. So we will do lateral rectus resection.
Resection.
Yes, and because the angle is moderate to large, 35, one lateral rectus resection will not be enough. So here I did bilateral lateral rectus resection. Okay. So this is the patient preoperatively, and post bilateral lateral rectus resection. Okay?
Doctor, what is the maximum millimeter I can do for recession or resection to decide it
Okay,
is only
that is a
muscle
good.
or two muscle?
So for medial rectus, usually we do not go beyond medial rectus recession. Usually the maximum 6 to 7 in some references. I personally do not go anything beyond 6.5 millimeter recession of the medial rectus. Okay. For the lateral rectus, you can do up to 9 to 9.5. In some references, even up to 10 millimeter recession of the lateral rectus. And why we can do more recession on lateral rectus more than medial rectus? Why?
It is longer muscle than medial rectus.
I don't think so. The length of the muscle is almost equal. Both are around 40 millimeter. There is another reason.
The insertion of the medial rectus is
Okay, insertion of medial rectus is closer to the limbus. So logically,
yes.
you can do more recession on medial rectus if you will depend on the insertion. But there is another reason. What do you think?
More exposure of
Stronger.
the rectus muscle.
So actually,
Medial
there is something called arc of
medial
contact.
rectus is heavier and bulkier.
Arc of contact. So if you did anything beyond 6 millimeter of the medial rectus recession, the muscle will go beyond the equator and it will be not working properly. It will not be there will be convergence insufficiency. But in lateral rectus muscle, the arc of contact is larger, so you can do more recession without losing the activity or the action of the lateral rectus. Okay. Let me show you something. Just 1 second. I will just stop sharing to show you this slide from another presentation, so you will understand it better. Just 1 second. Can you see the presentation now?
Yes, sir.
Hello? Okay.
Yes.
So here,
Yes.
that is about the arc of contact. So the arc of contact is the area of muscle that is in contact with the globe. Because of the divergence of the orbits, the lateral rectus has the longest arc of contact of the rectus muscle, 9 to 10 millimeter. The medial rectus has the shortest arc of contact at 6 millimeter only. Okay? So because of that, for medial rectus muscle, if you do a recession more than 6 millimeter, then you will put the muscle beyond the arc of contact, and that will lead to under action of the medial rectus muscle and convergence insufficiency. Okay? But for the lateral rectus, you have a larger arc of contact, so you can do more lateral rectus recession without losing the contact and without having lateral rectus under correction. Is it clear?
Yes, sir. Thank you.
Okay. So, yeah. So the thing is how much for the medial rectus, we can do up to 6 in other references, 7 millimeter. For lateral rectus, 9 in some references, up to 10 millimeters. For superior and inferior recti, usually 6 to 7 maximum, not more than that. Okay? Okay. So we have here a case of over-corrected esotropia or consecutive exotropia. So in such patient, what will you do? Yes. So here, patient with consecutive exotropia, we have two types of patient with consecutive exotropia. One type, if the patient is having limitation of adduction, and other type where there is no limitation of adduction. Okay? The management, usually we start with treating amblyopia, orthoptic exercises, convergence exercises, prism correction, reducing hyperopic correction. For example, patient whom I have done for him bilateral medial rectus recession, and he is wearing full cycloplegic refraction, for example, +6 diopter hypermetropia, and he developed consecutive exotropia. What is the primary thing to be done? Cutting the plus. I will give lesser hyperopic correction. I will cutting part of the hyperopic correction. So for example, if the patient is having +6, I will give, for example, +4 or +3. So that will help in reducing the exotropia. Okay. Also, alternate patching therapy sometimes might help. For surgical management, if no limitation of adduction, you can do whether bilateral lateral rectus recession or bilateral medial rectus advancement. If the patient is having limitation of adduction, then you need to work on medial recti to do advancement of the medial recti. Okay?
There
So
are
that
some
is
cases which have a plus number and they are with with exotropia. So in that condition, do we have to give full refraction, or we have to
see,
give partial because they have exo along with the plus?
patient who has intermittent exotropia, and when I did for him cycloplegic refraction, he had hypermetropia. So if the patient is having mild hypermetropia, for example, +1 or +2, I can easily cut and do not give the glasses. Okay? But if the
Okay.
patient is having moderate to high hypermetropia, then you need to give partial correction, because that significant refractive error will affect the vision. Okay? So you need to give partial correction. For example, patient with exotropia and +5, +6 hypermetropia. Then you will do manifest refraction, and you will give the least plus that the patient will see 6 vision with. So you might
Okay.
give +3, +2.5 from the +5. But definitely you will not give the full cyclone, because full cycloplegic refraction will increase the exotropia.
And the exotropia will not improve with the correction of refractive error also. It will remain the same.
Surprisingly, some patient with exotropia and hypermetropia, when you give the glasses, like you give the partial correction of the hypermetropia, because the vision will improve and the fusion will improve, exotropia might improve in some patients.
Oh, okay. Okay.
And always remember, vision is more important than the deviation, the strabismus. So you need to take care firstly of the vision, then you need to take care of the strabismus.
Okay.
Yeah.
Okay. Yeah.
Okay.
Okay.
So
Thank you.
this is a patient who is 16-year-old male, systemically free, presented with outward deviation, post esotropia surgery 10 years ago. So what is the diagnosis here?
Consecutive X.
Yes. He had esotropia and he had surgery for esotropia, and after the surgery he developed exotropia. So that is a consecutive exotropia. Past ophthalmic history of esotropia at the age of 3 years, bilateral medial rectus recession 5 mm at the age of 4 years. You can see here patient is having right exotropia with mild limitation of adduction in both eyes. Mild limitation of adduction in both eyes. On examination, vision was 6669. Cycloplegic refraction, patient had +7 diopter. Alternate prism cover test at near, exotropia 40, at distance 35. Limitation of adduction -half, mild limitation of adduction. There is conjunctival scarring medially, OU. That means the patient had bilateral medial rectus recession. So what have I done in this patient? I did medial rectus advancement. Okay. And sometimes we need to do small resection with advancement because patient might have something called stretched scar or pseudotendon. So you need to resect that part. If you put your suture in the pseudotendon or the stretched scar, then the patient might develop muscle slippage post-operatively. Okay? And surprisingly, that is the patient pre-operatively. Post-operatively, immediate post-operatively, patient had a consecutive esotropia, but after 3 months, the patient is orthotropic. Until now, he is orthotropic now 2 years post-op. Okay, now we will shift to exotropia.
So, sir, what is the meaning of resection? What is the difference between the resection and the advancement?
Resection, I resect part of the muscle. Advancement, I advance the muscle to the insertion.
Okay. So you resect
Advancement means that the muscle was 10.5 millimeter from the limbus, 5 millimeter away from the original insertion. So I did advancement of 5 millimeter. I put the muscle again 5.5 millimeter from the limbus. That is the advancement.
So both are the strengthening muscle procedures.
Yes, both strengthening procedure, resection and advancement. Okay.
So same muscle, you first cut it 2 millimeter and then you advanced it and put it over the previous insertion site.
Yes. And why I did resection here? Because the patient had a stretched scar. If you put your suture in that part, the stretched scar, then the muscle might slip again. You need to put your suture in a proper muscle. Okay.
So one
there can be simply
whether
advancement can also tighten it up, right? If in
Yes.
some cases like LPS, we do LPS advancement if there is ptosis. So that is also different from resection, and it is just what we do. I mean, in advancement without resection.
You just shift the muscle. You advance it anteriorly.
Okay.
Anteriorly toward the original insertion of the muscle. Okay. Okay.
So my question was. Yeah, my question was, can't we use the lateral rectus recession to correct this?
Yes, of course you can. But as I mentioned before, if you have a limitation of adduction, then it is better to do medial rectus advancement. But if you have no limitation of adduction, then you can go whether for medial rectus advancement or lateral rectus recession. You have the choice. You can choose whatever you want to do. But always put on your mind, if you use your lateral recti, then if the patient had a residual exotropia or recurrent exotropia, what will you do?
Right.
So it is always better to start with advancement and leave the lateral recti if the patient need a third surgery in the future, after 1 year, after 5 years, after 10 years. Okay? Okay. So we will go to exotropia very fast. Starting with this patient, when you see this picture, here patient is ortho, here patient is exo. So he has intermittent exotropia. Okay. So in such patients, sometimes he will be ortho, sometimes he will be exo. Okay. So when we classify exotropia, how would you classify it?
It can be divergence excess exotropia and convergence insufficient. And the divergence excess, it can be true one or the simulated one. And it can be basic exotropia.
Okay.
It will be
And
constant and intermittent first, the broad classification.
Okay. What
It
else?
could be comitant and incomitant.
Yes, always remember this, guys, please. Commitant,
okay.
incompetent. Then you say whatever you want to say. If you forget this, you will forget all the third nerve, exotropic duane, other types of incompetent
Orbital
exotropic.
views.
Yes, so always remember to classify it commitant, incompetent. And in the commitant exotropia, we have congenital or infantile exotropia, and we have acquired. In the acquired commitant, we have primary, whether intermittent or constant, and we have acquired secondary, whether sensory exotropia or consecutive exotropia. And in incompetent, we have third nerve palsy, we have exotropic Duane retraction syndrome. Okay?
Yeah.
Okay.
Yes.
So congenital or infantile exotropia, it has many things like infantile esotropia. The age of presentation usually at birth or before the 6 months. Large constant exodeviation. Sometimes they have also dissociated vertical deviation or inferior oblique overaction. And here the main difference between infantile exotropia and infantile esotropia, that infantile exotropia, many of them will have neurological disorder. So whenever you have a patient with infantile exotropia, you need to check for the developmental milestones. If you have any doubt that the patient is having delayed milestones or any neurological disorder, you need to refer the patient to neurologist and do neuroimaging for the patient. Okay? But for infantile esotropia, usually patient is neurologically normal. Okay?
Yeah.
Okay. Infantile exotropia non-surgical management, we can start with patching, correcting refractive errors. Botulinum toxin sometime might be used for the lateral rectus muscle. Surgery is required in almost all the cases. Within the first few months of life, maximize the chance for binocular single vision to develop and persist. It is very rare disease. It is even rarer than infantile esotropia. Okay.
This
Coming to
infantile exotropia, are the children, is it safe for the Botox injection to give in the small children? And what is the dose that we will give?
Okay, so is it safe or not? Yes, it is safe.
Yes.
We can use it even in small children. It can be used. The dosage usually according to the angle of deviation.
Okay.
So if the patient, for example, is having exotropia of 30 prism diopter and you will give botulinum toxin for both lateral recti, you might give 2.5 or 3 international units for each muscle. But if the patient is having larger deviation, you can increase the dosage up to 5 international units. So usually when we give botulinum toxin, we also check the angle of deviation. If it is moderate, we can give smaller dose. If it is large, we can give larger dose. But there is no nomogram for botulinum toxin. You know what I mean? There is no specific dosage for each angle of deviation. But
And we don't know how much one unit will cover.
Roughly from 2 to 5 international units according to the angle. 2 to 5.
Okay.
From 2 to 5 international units. Okay.
Okay.
Sir, please,
So,
I want to know simple steps for Botox. Do we expose the tenon? Do we inject it at the insertion or the bulk of the muscle? Thank you.
Okay. Okay. So we have two approaches or two like two methods to give botulinum toxin, whether to give transconjunctival without opening the conjunctiva. Okay. We always give the botulinum toxin in the muscle belly, We do not give it in the tendon. We give it in the muscle belly. Okay. So usually we use a tooth forceps and hold the muscle belly between the forceps and give the botulinum toxin. Sometimes we use what EMG to guide us where is the muscle. And the other method to give botulinum toxin, something called open sky method. Open sky method means you will do conjunctival opening and you will hook the muscle and you will give the botulinum toxin in the muscle belly under direct visualization.
Okay.
So whether you will give it transconjunctival without opening the conjunctiva, or whether you will give it open sky under direct visualization of the muscle to make sure that you are giving the botulinum exactly in the muscle. Okay?
Okay.
Okay. So coming to the most common type of exotropia, which is the intermittent exotropia. So exotropia is the most common deviation observed in children between 7 and 12 years. Most adults will have small exophoria, usually less than 10 when fully dissociated. Clinical features, usually more common in females, noticed by parents in early childhood. Usually that is the age of presentation, 2 to 5 years. And it will manifest initially under the conditions of fatigue, illness, daydreaming after taking sedatives. Symptoms, many patients will have photophobia or closing one eye in a bright light. Without suppression, all the children and adults complain of asthenopia, blurred vision, headaches, diplopia sometime, visual confusion, reading difficulties. Okay. Natural history of intermittent exotropia. Usually patient will start with orthotropia at near, exophoria at distance. Then it will increase. It will be intermittent exotropia at distance and exophoria for near. Then exotropia at distance and intermittent exotropia at near. Then exotropia at distance as well as near. Okay. So because of that, many of those children, when you try to do alternate cover test at near, you will find the patient what? Ortho. But when you make the child look at a distant target and repeat the alternate cover test, you will reveal the, or you will see the exotropia. Okay? Signs of progression. How to know if that patient is having a progression in the exotropia? Increasing the frequency of manifest phase, increase in the magnitude, the size of deviation, the angle of deviation, and development of suppression, decreased stereo acuity. So intermittent exotropia, we classify it into basic exotropia, where the angle of deviation at near and the distance are equal or within 10 prism diopter. Okay? We have convergence insufficiency, where the angle of deviation at near more than distance, more than 10 prism diopter. And we have something called divergence excess, whether the angle at distance more than angle at near, more than 10 prism diopter. And in divergence excess, we have two types, whether pseudo divergence excess or true divergence excess. What is the difference? What is pseudo divergence excess?
It is because of tonic proximal fusion, and
Okay.
we ask the patient to look for a +4 prism diopter lens or uniocular patching is done to relieve the tenacious proximal fusion, to break it.
Okay, so patient with pseudo divergence excess, whether they have tenacious proximal fusion, and in those patients, usually we do monocular occlusion for 30 minutes or 45 minutes. Then we repeat the measurement at near. And if it becomes within 10 prism diopter from the angle of deviation at distance, so that is a simulated divergence excess because of tenacious proximal fusion. But some patient, even after monocular occlusion, still the angle of deviation at near is less than the angle of deviation at distance. So they might have something called high AC by A ratio. So use +3 diopter lenses to see if the angle of deviation will increase or not. If it increase, so that is simulated divergence excess because of high AC by A ratio. If the patient is still after monocular occlusion and after adding 3 diopter lens still having less deviation at near and more deviation at distance, that is a true divergence excess. Okay?
Okay.
Okay. So clinical evaluation, we have many things to document the control of those patients. There is something called Newcastle control score and Holmes office control score. Those score will help us to know whether the patient is having good control or fair control or moderate fair control or poor control. And accordingly, we will decide whether to do the surgery for the patient or not. Okay? Firstly, starting with the treatment of intermittent exotropia, the non-surgical treatment. What can we do for those patients?
Correction of refractive error over minus prescription should be given.
Yes, so
And
correcting significant refractive error. In small children, preschool children, we can give over minus glasses because over minus glasses will stimulate the convergence, then so it will help in reducing the exotropia. What else?
and occlusion of the good occlusion.
Amblyopia therapy. Amblyopia therapy can be done if the patient is having amblyopia on one of the eyes. Some doctors will also do alternate patching as an anti-suppression exercise, and it will help in having better control. And orthoptic exercises also can help in some patients.
Yes.
Okay, especially in patient with convergence insufficiency. Patient with convergence insufficiency exotropia will get benefit from orthoptic exercises. Okay. Then we will go for the surgical treatment. Indications of surgery usually poor control, increasing the tropia phase, increase in the angle of deviation, deterioration in the stereo acuity. In those patients, we will do surgery. The timing of surgery, what is the time of surgery for intermittent exotropia?
School age.
When
What
the
age?
exotropia remains more than 50% of the time of the day, then
Okay.
it's the time when we do the surgery, according to
Okay.
Newcastle.
Okay. Okay. So as you mentioned, poor control and all that will help you in deciding that this patient need surgery. But usually in those patients, we do not recommend to do surgery before the age of 4 years. Why?
Because
Why?
the angle need a vary.
Why?
It's not still
Sometimes
Because if those patients develop consecutive esotropia, they will lose the fusion or they will lose the binocularity forever. Okay? And also, esotropia is more amblyogenic than exotropia. So you might give the patient amblyopia. Okay? So if you are doing the surgery, it is better to do the surgery after the age of 4 years. So the patient will have more mature fusion centers, and the patient will have lesser risk of amblyopia. So the best age for surgery is 4 to 7 years of age, but sometimes we might need to do the surgery earlier. But it's always preferable to wait till the age of 4 at least. Okay?
So this fusion center of the eye, it matures by the age of 4 years?
Not the fusion center. The fusion and the binocularity, all those centers usually they will need time to mature. It will not be fully mature or complete maturation by birth. So usually within the first years of life, maturation will happen.
Okay.
Okay. So if you do surgery in a very early age and you develop consecutive esotropia, patient will have loss of fusion and higher risk of amblyopia. So it is better to defer the surgery till the age of 4 years, unless the patient is having constant, very large exotropia, and you tried everything, the alternate patching, the over minus glasses, everything, nothing work, then you can do the surgery. But if you do surgery in a small children less than 4 years, you do not aim for overcorrection, you aim only for orthotropia.
Okay. So
In,
these type of
in
like even in Duens and these intermittent exotropia, they say that wait. I mean, like in
Yes,
Duens also they say wait till 7 years. I mean,
yes.
decide the surgery after 7 years. So the principle is the same. The thought is the same that we want to have full fusion. After that, we want to check.
Yes. Also
Uh,
because you will be able to have more persistent angle of deviation. You will make sure that you treated amblyopia properly before the surgery, and you did all the non-surgical management, whether alternate patching or over minus glasses. You used all your weapons, then you don't have anything other than surgery after that.
uh, okay.
Okay. So here the surgical for patient with basic exotropia, you might do bilateral lateral rectus recession or unilateral lateral rectus recession and medial rectus resection. In true divergence excess, it is always preferable to work on lateral recti only. Why? Because the deviation at distance is more than the deviation at near, and lateral recti are responsible for that difference between near and distance. So in true divergence excess, it is always preferable to do bilateral lateral rectus recession. In patient with convergence insufficiency, whether to do unilateral lateral rectus recession and medial rectus resection or do bilateral medial rectus resection, but we usually do recess resect. Okay.
Okay.
Post-operative management, always desirable to discuss the post-operative result expected, especially if overcorrection is planned. Usually in patient who is older than 5 years or 6 years with good vision in both eyes, in patient with exotropia, we usually aim for small overcorrection. We prefer to leave those patients around 5 to 10 present diopter of esotropia. Why? Because usually drift will happen after the surgery. So it's preferable to leave those patients with a small esotropia initially. And with time, exotropic drift will happen and they will be ortho within 1 month, 2 months, 3 months. Okay.
Drift will happen with whatever the procedure we choose, whether lateral rectus recession or medial rectus resection and lateral rectus recession. In both the cases, drift will
Yes.
happen.
Yes. Yes, definitely. Remember, the resting position of the eyes is the exo. That is the resting position of the eye. Because of that, usually the risk of recurrent exotropia is much higher than the risk of recurrent esotropia. Okay?
Okay. Okay.
Yeah. Coming to convergence insufficiency, type, we are almost done. Convergence insufficiency type. In those patients, exercises will help a lot. So start with convergence exercises. And if patient does not improve, you can go for the surgery. Coming to some of the cases, this is a case of 22-year-old male, systemically free, presented with outward deviation, more in the right eye, more than 3 years. He doesn't know exactly when it started. Vision 6669, fixation central steady maintained OU, but he has preference. Alternate prism cover test at near exotropia of 50 prism diopter. Alternate prism cover test at distance, exotropia of 50. So he's having same deviation at near and at distance. So what is the type of exo?
Constant.
Constant, basic.
Basic. Yes.
And he's having a small vertical deviation, right hyper deviation of 9 prism diopter with no overaction, no inferior oblique overaction or superior oblique overaction. So in such case, I have done bilateral lateral rectus recession 7 millimeter with right eye medial rectus resection 6 millimeter, because here we have 50 prism diopter. So usually anything beyond 40 prism diopter, we do 3 muscle surgery in exotropia. So BLRC 7 with right eye medial rectus resection 6 millimeter. And I did downshift for both LR and MR in the right eye to correct the right hypertropia. Okay?
Yeah.
Yeah. This patient, 2.5-year-old, this is what I'm telling you. 2.5, 2 years and a half. Presented with outward deviation at the age of 1 year. He's having large exotropia, 50 prism diopter, with very large inferior oblique overaction. Can you see here the eye? +4
Yeah.
inferior oblique overaction in both eyes. Cycloplegic refraction only +1, anterior posterior segment normal. Started the patient on alternate patching over minus glasses, but compliance was very poor. Angle of deviation was stable over multiple visits, so I decided to do bilateral lateral rectus precision of 10 millimeter plus inferior oblique anteriorization or anterior transposition to treat the severe inferior oblique overaction. And you can see postoperatively patient is orthotropic with no inferior oblique overaction. So as I mentioned, in some cases where the patient is having large constant exotropia and you tried everything, nothing works, then you can go for the surgery. But if you go for the surgery, do not aim for overcorrection, aim for orthotropia. Okay? I think this is the last case. 5-year-old female presented with outward deviation since 3 years, having 6/9 vision in the right eye, 6/36 vision in the left eye, cover test exotropia 50 prism diopter at near and at distance, and she had left eye DVD and inferior oblique overaction, starting with giving the glasses, patching right eye 6 hours daily for 6 months. After vision in the left eye reached 6/12, I did the surgery and completing the patching after the surgery. The surgery here, because the patient had amblyopia in one eye, we did lateral rectus recession and medial rectus resection with inferior oblique anteriorization to treat the DVD and inferior oblique overaction. Okay. Last case, I think 14-year-old female with a very large exotropia, 85 at near, 80 at distance with full extraocular motility. In such patient with very large angle, usually we do 4 muscle surgery. So I did bilateral lateral rectus recession and bilateral medial rectus resection to treat the whole angle of deviation with using adjustable suture to make sure that I get the proper alignment after the surgery. So I hope with those 12 cases and with the discussion, esotropia and exotropia now is more understandable. I think we have only the sensory exotropia in this patient. Patient is having very poor vision in this eye. You see the peaked pupil. So I use Kremsky test over the good eye to know the angle estimation in the exotropic eye. And usually in patient with sensory exotropia, we do unilateral recess resect in the poor vision eye. So thank you so much.
Can you please tell something about accommodation gradient? How we measure AC upon A ratio?
Okay, so AC by A ratio, simply if the angle of the, for example, patient with esotropia, if the angle of deviation at near more than angle of deviation at distance more than 10 prism diopter, so by default, this is a patient with high AC by A ratio. Also, when you use plus three diopter lens, so for example, patient had angle of deviation at near 40 prism diopter, okay? And when you use plus three diopter lens and you repeat the measurement for the angle of deviation at near, you find it, for example, 10. So that is 40 minus 10, that is 30 prism diopter of correction over 3, the diopter, the lens that you, so 30 divided by 3, that is 10. So that patient has high AC by A ratio 10 to 1. That is
Okay, because it is 10.
Yeah, that is
10 is
yeah, that is one way to measure it, and there are other methods, but you will need to use the interpupillary distance. So that is the easiest one actually. You can use it simply.
okay. So we subtract the one which is the distance as well as the near, whatever the difference is there, and then divided by the number of the lens that you put. That is, we always put 3 diopter, or we put we can put any
You can
number.
do plus 2 plus 3. See, I mentioned now two methods. Whether if the measurement at near more than the measurement at distance more than 10 prism diopter, so that is high AC by A ratio. Okay, simply.
Okay, yeah.
If you want to know exactly what is the AC by A ratio in the patient, so you will measure the angle of deviation at near without any addition.
Yeah.
So for example, in the example I gave you, the angle of deviation at near is 40 prism diopter ISO. And with adding the plus 3 diopter over 2 eyes, the angle of deviation at near reduced to 10 prism diopter.
Okay.
So 40 minus 10. So the 3 diopter lens corrected 30 prism diopter of esotropia.
Okay.
30 divided by 3, that is 10.
Yeah.
So the AC by A ratio is 10 to 1.
Yeah.
Yes, that's it.
Okay. Okay.
Thank you so much. And
Sarah, I have a question, please.
Yes.
If it's a case of exotropia and the angle of deviation for near maybe 25 and for 45, which angle I will work in, or I will work on the average?
Okay, so in exotropia, we usually go for the largest angle, especially in your example, the difference is only 10 prism diopter. So it is preferable to go for the largest angle. Okay?
Okay.
But on the other
And
side,
Okay.
yes, on the other side, if the patient with esotropia at near, for example, 40, at distance 30, I will go for the 30. I prefer to have a small residual esotropia at near 10 prism diopter rather than having consecutive exotropia at distance. Because if the patient started to have consecutive XT, most probably that XT will increase with time.
Okay.
Yeah. So that is very important question. Thank you so much.
Another question, please. Another question.
Yes.
When I tell that this case is alternate exotropia or alternate exotropia with unilateral predominance as right predominance.
Uh-huh.
or left predominance?
Uh-huh. So
When I say
alternate.
this and when I say this.
See, most of the patients with exotropia, most of them will prefer one of the eyes, even if the vision is equal in both eyes. Mostly they have a slight preference in one of the eyes. So if the patient is having alt- freely alternate fixation when I'm doing the fixation preference, for example, when I close the right eye, he will fixate with the left eye. When I uncover the right eye, he will keep fixating with the left eye, and the same thing with the other eye. So that is alternate exotropia. But if the patient is having preference of fixation in one of the eyes, so that is, I will call it whether right exotropia or left exotropia.
Okay, but how can I differentiate its alternate with unilateral predominance or its unilateral exotropia?
With the cover test, alternate cover test, you will do the cover test, for example, covering the right eye, then removing the cover from the right eye. If the patient keeping fixation with the left eye, so he is having maintaining fixation with the left eye, then you will do the opposite. You will cover the left eye and then you will uncover the left eye. If the patient kept fixating with the right eye, then that patient is having alternate exotropia. If, for example, I covered the left eye, patient became, and then I did uncover for the left eye, and immediately after uncovering, the left eye drifted outward, so that is left exotropia. You got the point?
Okay.
So it depends on the fixation preference. You will do the CSM method in both eyes, and you will check whether the patient is having preference one of the eyes or alternating fixation with both eyes and no preference of one of the eyes. But most probably, most of the patient with exo will have one eye with preferred fixation.
Okay, thank you.
Okay, thank you so much. Any other questions?
Dr. Amr, thanks a lot for your lecture. Really very beneficial and illustrative. Thank you for your patience as well. May I ask you a question related to pediatric ophthalmology, but not strabismus?
Yes.
Do you prefer, or in your practice, if you are having a patient like at 7 to 8 years old who has eye syndrome and having cataract and corneal opacity, would you go for triple procedure in such patients? And if yes, what's the type of the IOL you would prefer to implant? Thank you.
So the patient is having eye syndrome, iridocorneal endothelial
syndrome. Yes.
Yes. So the problem with such patient, usually they have amblyopia. They will have glaucoma. And if that added up with cataract, so usually prognosis is not that good, but definitely it's preferable to do the triple procedure and very aggressive amblyopia therapy afterwards. And you need to counsel the family that even after doing everything, you might end up with a poor vision, or like poor visual prognosis.
At which age would you prefer to put the IOL? It's okay at 6 to 7 years old, 7 to 8 years old, right?
Even earlier, actually. Even earlier.
Maybe
even
by
earlier,
6? Oh, yeah. Okay.
Even earlier. Even earlier. And the IOL of choice in children usually single piece hydrophobic acrylic IOLs. That is the best type of IOLs to be implanted in children. Unless you are putting the IOL in sulcus, then you will use the 3-piece IOL acrylic.
Okay. Would you rather put the lens in sulcus, or you try your best to implant it on the remnant of the bag? Yeah.
Definitely bag. Always bag is better for children and for adults as well, but for children because they have a longer lifespan. So it's always preferable to put the IOL in bag. If you cannot put it in the bag for any reason, at least do optic capture. At least do optic capture for the 3-piece IOL. So the haptics will be in the sulcus and the optic will be in the bag. Okay.
So at what age can we put
Thanks, sir.
IOL? Like suppose we operated at 2 years or we operated at 1 year. So what is the age at which we can put IOL in these type of patients?
For congenital cataract patients, if the patient is having unilateral congenital cataract and the patient present at the age of 6 months or 7 months, I will put IOLs immediately. I will put IOL immediately. So for unilateral congenital cataract, you can implant IOL as early as the age of 6 or 7 months. Okay? If the patient is having bilateral congenital cataract and the patient present at the age of 1 year, for example, then you can implant IOL after the age of 1 year, primarily. Okay?
Okay.
For bilateral, at least the age of 1 year. For unilateral, the age of 7 months. Why we do earlier IOL implantation in unilateral cases? Because of the risk of amblyopia.
Okay.
Okay. So that is when we
But
put
why the other
IOL
people were
primarily.
some people they are writing that we should put the IOL at after 2 years of age and just use contact lenses or
That is the secondary IOLs. For example,
I
the
mean,
patient with bilateral congenital cataract present at the age of 2 months. Definitely, I will not put IOL. I will do only lensectomy for the patient with anterior vitrectomy, and I will leave the patient aphakic. And when the patient is 2 years or 3 year old, and IOP is normal, retina is good, everything is okay, corneal diameter is fine, axial length is okay, then I will put secondary IOLs at the age of 2 or 3 years.
Okay.
That is secondary. But I'm talking about primary IOL implantation. Primary means at the same time of doing the cataract surgery.
Yeah, so how we will choose that we should do it primary or wait and do it secondary?
Depend on the age of presentation, doctor. So if the patient with unilateral cataract present late at the age of 7 months, so I will do cataract and IOL implantation on the same session.
Okay.
But if the patient present earlier, then I will do only lensectomy without IOL implantation, and I will do IOL implantation later. Same thing with bilateral patient with bilateral cataract. If the patient present late at the age of 1 year, for example, so it's preferable to put the IOL on the same procedure. But if the patient present earlier at the age of 2 months, then I will do only lensectomy and do IOL implantation secondarily on a later date.
Okay, so it is preferable to put IOL after 6 months of age. That means if the patient is presenting at 6 months or after 6 months, then we can put. Otherwise, we will wait.
Yes, in unilateral. In bilateral, after the age of 1 year, because risk of amblyopia is lesser. Bilateral congenital cataract, you can fit them with aphakic glasses or contact lenses, and they will do very well. The risk of amblyopia is lesser because he's having bilateral problem.
Yeah, okay. What about the scleral fixated IOLs? What about the scleral fixated IOLs? Suppose something happens to the PC and we are not able to put it in the capsular bag and we are not able to do optic capture, then what do you think that we can do iris claw, we can do ACIOL, or we should go for scleral?
ACIOL not recommended in children at all. At all. Not recommended at all because the life expectancy is high, as we mentioned. So whether you will do iris fixated IOLs, whether anterior iris fixated or posterior iris fixated or scleral fixation IOL, but both of them usually we do it on a later age, after the age of 6 years. Okay, we do not do scleral fixation in small children because the eyeball still will grow and the IOL position will change. So usually scleral fixation IOL usually will not be done before the age of 6 years. Also iris fixation IOLs also at the same age, around 6 years or older.
Okay, okay, thank you.
Any other question?
Excuse me, Dr. Amr, once more. Would you go for keratoplasty at the same setting with the cataract surgery? I would like to just be sure about this point.
If the patient is having significant corneal opacity, then I think yes, you will do the whole thing
triple?
together. Yes,
Yeah. Yes.
because
Okay.
yeah, it's preferable. Yes.
Thank you.
Okay.
Sir, in unilateral cataract, what's the ideal time to do the lensectomy and in bilateral?
Okay. So you talk about the timing of the surgery. صح?
Yes, the surgery.
Yes. For unilateral, usually 4 to 6 weeks. 4 to 6 weeks of age. That is the earliest age that you can do unilateral cataract surgery. For bilateral, usually 8 weeks, 2 months, 8 weeks. That is the earliest age you can do surgery for. Okay?
Okay, thank you.
So unilateral, 6 weeks, bilateral, 8 weeks. Yeah.
So what
Okay.
can be the issue if they are operated before that?
The problem is the risk of post-operative glaucoma is very high because the
Okay.
angle structure is not developed yet. So that is the main issue. And they studied the critical period for the amblyopia to develop if you do the surgery for unilateral before at the age of 6 weeks, it will give you the same result if you did it earlier. And for bilateral,
Okay.
if you did the surgery at the age of 8 weeks and earlier, it will give you the same result. So it's better to defer the surgery unilateral at the age of 6 weeks, bilateral 8 weeks, to have a good visual acuity and also lesser risk of glaucoma.
Okay.
Doctor, in these cases, you leave the patient aphakic for secondary IOL implantation
Yes,
later
yes,
on?
definitely, aphakic, definitely. Those young children, we don't put IOLs. Some trending now, they are putting IOLs in earlier ages, earlier age, but still it is under investigation.
Not less than 1 month, 1 year, right?
For bilateral, yes. For
Okay.
unilateral, 7 months.
Okay.
Yes. Any other question?
So what IUL formula will use for calculating them? Which one is the one?
Usually, SRKT is very good for children.
SRT?
SRKT. And if the patient is having a very small eye, then you can go for Higgis. Sorry, for Hofer.
Hoffer Q.
Yes.
And
Many
will
thanks,
we do
doctor.
any undercorrection or overcorrection about it? Like they say
Definitely.
that whatever comes, make 20% undercorrection and or make
Do under
like that.
correction for all children. You will do under correction for all children. There are many ways to do the under correction. One of them is doing 20% under correction if you are doing the IOL implantation in a patient less than 2 years, then 15% under correction from 2 to 3 years, then 10% under correction from 3 to 5 years or 3 to 6 years. And the other way to do under correction is 7 minus the age of the patient. So for example, you are implanting IOL at the age of 1 year. So 7 minus 1 equal plus 6. So you will do under correction plus 6. You will keep the patient with plus 6 hypermetropia. If the patient is 3-year-old, so 7 minus 3, that is 4 plus 4. So you leave the patient hypermetropia plus 4. What does that mean? Plus 4 hypermetropia. So if the IOL biometry gave you, for example, plus 30 emetropia, so I will put plus 26. I will give lesser power.
Okay.
Why I am doing that? Because I am expecting that the eye will grow and myopic shift will happen.
Yeah.
So when the patient is 6 or 7-year-old, he will be emetropic. But if I put the same IOL power that will give emetropia at the age of the surgery, when the patient is 7 or 8 years, he will be minus 9, minus 7, minus 8. He will have a very high myopia. Yes.
Okay. Yeah, got it. Thank you so much.
Thank you so much for everyone. And we can do other classes about cataract and other pediatric ophthalmology topics, inshallah.
Please, please, just 10 days left, Dr. Amr. So if you can this week, we will appreciate it.
I will try
Yeah,
my best.
because we want, so we want the topics, important one, like cataract and eyes, all that, features and anomaly. And also we want the
If you can,
retinoblastoma and ROP, if you can do it, please.
you can write on the group all the topics, then I will try to make another class shortly, inshallah.
Thank you.
Okay.
Thank you so much.
Thanks a
you
lot,
so much.
Dr. Amr. Thank you.
Thank you so much.
Thank you so much.
Thank you. Bye.
Thank you. Thank you. Bye bye.
Thank you, Dr. Koshik. Bye.
Thank you, Dr. Amar. I think it is better if you can take a class. I think the candidates will be very much helped on the topics which they suggested.
Yes,
like
yes,
cataract,
definitely.
ROP, etc. Because the
Yes.
exam is on 23rd June.
Yes, I think, yeah, we can do it within, the next few days. I'm ready, inshallah.
Okay. Thank you.
And
Thank you so
thank
much.
you so much for
Thank
your
you.
help, Dr. Koshik. Thank you so much for your support.
Thank you.
Really
Dr. Amar.
appreciate it.
Yes.